Okay, so we're going to go over muscle energy for the fibular head. And first step in order to perform any kind of muscle energy technique is understanding the diagnosis that you're going to be treating, right? So we're going to need to think about the diagnosis of the fibular head and understand what it is that we're looking for. So the two primary motions of the fibular head are going to be anterior motion and posterior motion. And the ways that we're going to evaluate that, first we're going to evaluate it statically. So we're going to be comparing one side to the other. So of course, anytime you're doing that, you want to put your dominant eye over that limb or over the center of the patient's body. And we're going to focus on the right leg for now. And you want to look at the fibular head. So you want to make contacts anterior to the fibular head and posterior to the fibular head. And you're going to want to look at that fibular head in space. And for static comparison, you'd want to also check the other fibular head at the same time and kind of get a feel, not only visually, but a feel in your hands proprioceptively where that fibular head lies in space. Your next step is to assess it dynamically. And the way you're going to be doing that is you're going to stabilize the lower leg and you're going to push that fibular head posterior, in a posterior direction. And then you're going to be pulling it anteriorly. And you're going to be assessing for freedom of motion and restriction of motion, like any somatic dysfunction. The next step after that, and to enhance that kind of motion, what we're going to be utilizing is reciprocal motions of the fibula at the distal fibula. So to think about how that's going to occur, what we should be thinking about is the fibula, of course, as a long bone that goes proximally from the lateral knee to distally at the lateral ankle, at the lateral malleolus. So these are the two ends, and that bone is going to be bound to the tibia by the interosseous membrane in between. So in terms of its motions, if you think about two free ends that are bound in the middle, you would think that, or you would correctly presume and deduce that the fibula would move in a seesaw motion. So as the anterior, as the proximal fibular head moves anteriorly, the distal fibula would move posteriorly, and vice versa. So in order to assist that motion, enhance that motion, what we're going to be using is dorsiflexion and plantar flexion of the ankle. So with dorsiflexion of the ankle, we would expect the distal fibula to move posteriorly. And if that's moving posteriorly, we'd expect the fibular head to move anteriorly at the same time. With plantar flexion, we would expect the distal fibula to move anteriorly and then the fibular head to move posteriorly. Also, in terms of ankle motions, we should think of dorsiflexion and eversion as paired motions and plantar flexion and inversion as paired motions as well. So each of those we're going to use to enhance the motion of the fibula. So in testing, initially on my dynamic test, I am feeling that the fibular head translates anteriorly well, but does not translate posteriorly well. That suggests that there's a freedom of motion anteriorly and a barrier of motion posteriorly. When I dorsiflex the ankle, I'm expecting the distal fibula to move posterior and the fibular head to move anteriorly. And when I do that, when I dorsiflex and evert, I do feel good motion at the fibular head, which supports a freedom of motion anteriorly. When I plantar flex and invert, I find that the fibular head does not move as well, which supports a barrier of motion posteriorly. So in naming our fibular dysfunction by our freedoms and barriers, we would then have an anterior fibular head as our diagnosis. So in order to treat that now with muscle energy, what we're going to be doing in any kind of post-isometric relaxation muscle energy is we're going to be positioning the segment into its barrier. And the way we're going to do that for an anterior fibular head is we're going to support it anteriorly and push it posteriorly. We're going to support that motion by plantar flexing the foot and inverting the foot, which will move the distal fibula anterior and the fibular head posterior into the barrier. At this point, we would ask our patient to dorsiflex their foot as we apply an isometric resistance. And then we have them relax after a few seconds. And we're also going to relax at the same time. We're going to pause, and then we're going to feel as our fibular head drifts through its barrier and starts to move posteriorly. And we're going to also enhance that by additional plantar flexion and inversion. It's very, very small motions. And then we're going to have our patient again dorsiflex as we apply an isometric resistance. And then relax. And we're going to pause. And then follow to the next barrier. We'd repeat that 3 to 5 times, and then we'd reassess for improved motion. Alternatively, and in order to kind of help isolate the motions that you're inducing to the fibula and the fibular head, you can also add a little bit of knee flexion. So in that flex knee position, you would expect still the fibula to behave in that reciprocal motion pattern. So if you remember, our somatic dysfunction is an anterior fibular head, which means a freedom of motion anteriorly and a restriction of motion posteriorly. So in order to enhance that posterior motion, we're going to be plantar flexing and inverting the foot, which moves the distal fibula anteriorly, and also aids in moving the fibular head posteriorly. We're going to support that. And again, we're going to have our patient dorsiflex against an isometric resistance. So go ahead and lift your foot up. And then after a few seconds, you would have them relax, and you'd relax as well. Follow it to the next barrier. And then again, and relax. Follow it to the next barrier. Repeat 3 to 5 times, then return back to neutral, and then reassess fibular motion. Go. All right, so now if we had a somatic dysfunction of the fibular head that was a posterior fibular head, which suggested a freedom of motion in the posterior direction for the fibular head and a barrier of motion anteriorly, we would do the opposite of what we had done in our other technique. So we would position our fingers posteriorly, we'd position our fingers posterior to the fibular head, and we'd translate the fibular head anteriorly into its barrier. We would also enhance that motion by dorsiflexing the ankle and everting it, which would move the distal fibula posterior and would also assist in driving that fibular head anteriorly. And we do that until we approach the barrier. We would then ask our patient to plantar flex against an isometric resistance. So go ahead and point your toes as we resist, and then go ahead and relax. As they relax, we relax, and then we follow that fibular head into the next barrier, which would be the fibular head would move anteriorly and the distal fibula would move posteriorly, and we would evert and dorsiflex, and then we would have them point their toes again. Go ahead and push down, point your toes as we resist, and then we have them relax. We relax, we follow to the next barrier, and then we repeat 3 to 5 times, return back to neutral, and then assess fibular motion.